Good afternoon, everyone. I show it's 1 o'clock, so we will go ahead and get started. It's my pleasure to welcome you to today's program. My name is Donnie Green, and I work with the North Central Texas Area Agency on Aging. It's my pleasure to moderate today's town hall, which has been planned by the University of North Texas Health Science Center's We Hail program under the leadership of Susanna Luke Jones. Funded by the Health Resources and Services Administration, We Hail is a geriatric workforce enhancement program that has been improving health outcomes for older adults in Greater Tarrant County since 2015. It is an interagency effort with support from the United Way of Tarrant County and other community partners. Today, we have several experts at the county, regional, and state level who will be addressing current and ongoing issues faced by long-term care facilities. We'll focus on topics that include staffing considerations, patient care concerns, and continued precautions. We've chosen our panelists carefully in order to represent several perspectives. We have 3 doctors and a nurse practitioner who will speak to patient care issues, drawing on vast experience that includes treating patients, teaching medical students, and serving as medical director of a long-term care facility. We have a nursing facility administrator who will share best practices. We have the state long-term care ombudsman and the director of regional regulatory services who will draw on vast knowledge of policy issues. We have an emergency responder who's on the cutting edge of caring for local citizens affected by the pandemic. And here are our speakers. Our panelists include geriatrician Dr. Janice Knabel, professor of geriatrics with the University of North Texas Health Science Center in Fort Worth, geriatrician Dr. Sarah Ross, assistant professor of geriatrics with UNT's Health Science Center, Texas State Long-Term Care Ombudsman Patty Ducaye with the Texas Health and Human Services Commission, geriatrician Dr. Anthony Burton, Associate Program Director for the Geriatric Medicine Fellowship at JPS and Medical Director for Arlington Heights and Rehabilitation Center in Fort Worth. And it's important to note that Arlington Heights does participate in the Medicaid program. Nat Zavotsky, who is Chief Strategic Integration Officer with MedStar, Bailey Hillman, Vice President of Operations and Healthcare Administrator of James L. West Dementia Care Center in Fort Worth. James L. West is a private not-for-profit facility. Elizabeth Tommy, Regional Director of Long-Term Care Regulatory Services with Texas Health and Human Services Region 3. And geriatric nurse practitioner Barbara Hardy of the University of North Texas Health Science Center. Today's program is structured in question and answer format. We will respond to questions that were generated prior to the program and do our best to carve out time to respond to questions that you may submit during the program today. To control for background noise, all participants will be muted. If you'd like to ask a question, please submit via the chat function. And when the program is completed, I'll give you instructions on requesting continuing education units for social workers and licensed professional counselors. So in order to set the stage for our conversation this afternoon, I would like Dr. Knabel to provide information on COVID-19 in long-term care so that we can understand the current state of affairs.
Good afternoon, everyone, and happy to participate today. And first, before I get started, just to say a very big thank you to all of you that are working in long-term care, whether you are the frontline care team, administration, or those that are trying to serve those individuals living in long-term care today. It has been clearly a challenge, as you can see from this slide. For most states, at least a third of COVID deaths have been in long-term care facilities. Unfortunately, nursing facilities have really been at the center of this pandemic. From my perspective, that includes not only the residents, but all of the direct care staff and the care team in long-term care. We know that these congregate type of settings have higher risks, and we also know that the residents that live within long-term care facilities certainly are older, have more comorbidities, frailties. Many times, dementia is another condition that will make this all the more challenging. And certainly, more than at least one activity of daily living that individuals need support from a care team member. So certainly a recipe for the challenges that we've had. Next slide, please. So currently, CMS has been offering lots of guidelines and support. I'm sure many of you have accessed these resources regarding the visitation guidelines. We are still under no visitation by family members to facilities to see their loved ones. Then we have CMS reporting guidelines that have come out. CMS has also put together a partner toolkit. CMS has further introduced and announced a new independent commission that is going to conduct a comprehensive assessment of the nursing homes in response to the coronavirus 2019. And finally, CMS is now in the process of drafting some guidelines as to how to begin to reopen nursing facilities and how to balance that challenge of protecting the residents and providing access to family members and loved ones. So there will be more coming out, and certainly these are very good resources and sites to utilize. So please access these as you are trying to provide the care within your long-term care facility. Next slide, please. Okay, so legislation is certainly being looked at in terms of quality care for nursing home residents, and then the Nursing Home COVID-19 Protection and Prevention Act, which would actually provide $20 billion in emergency funding for staffing, testing, PPE, and more resources. They are really trying to invest in promising practices to save lives, safeguard the residents, and then be able to collect the COVID-19 data and required disclosures. So more will be coming on that. Next slide, please. And lastly, there have been several initiatives to support long-term care. The Institute for Healthcare Improvement, in collaboration with the John A. Hartford Foundation, created a nationwide rapid response network for nursing homes, and they are having daily huddles that are occurring at 12 noon Eastern Time every day. These huddles last about 20 minutes or so, and certainly something I would recommend to consider turning to obtain some useful and helpful information. And then at the state and local levels, there are emergency medical task forces for work between EMS, DHS, HSC, local authorities to really work together to try to assist in the current COVID pandemic, focusing on long-term care. So thank you so much for the opportunity to update all of you, and I'm going to turn it back now to Donnie.
So we're going to start by talking about staffing considerations, if we can move to the next slide. And would love to hear from our panel about infection control efforts. How is PPE being managed? Are masks being reused? What about N95 respirators? What types of infection control trainings are available? And would love to hear from first Dr. Burton as medical director, and then would also like to hear from Bailey Hillman as an administrator and Matt Zabotsky as an emergency responder. So Dr. Burton, can you start by talking about infection control efforts?
Yes. So initially, when all this started, we put together a COVID specific infection control team that's made up of myself, our assistant director of nursing, and several of the main nurses in our facility. And so they're the part of the team who conducts the testing and manages the PPE. Specifically, we are administered masks on a weekly basis, surgical masks that all staff and all residents actually wear throughout the facility And if you look at the picture on this slide, that's how the masks are kept for all of our staff, in brown bags. And we get checked with a standard screening tool every time someone starts their shift. And they get asked about, fevers, cough, any exposure risks, things like that. And then they get their temperature monitored. And then they go about their shift. When they're seeing patients, for new admissions, they have to wear full PPE with the mask, face guard, N95 mask, and those are all stored in a specific room on our 3rd unit in the facility. And so the nurses know to go to that room to get their specific PPE. Gowns are changed every single day, but they reuse them throughout the day unless they get soiled. And N95 respirators are being used essentially until they get soiled or are unusable as well. Yeah. And as far as face coverings, we're making sure that the N95 mask is fitting securely as possible, and so that they don't wear things under the N95 mask, which makes it less helpful. And so any other face mask that someone wears would go on top of it. And the facility can clean like cloth masks if people choose to wear those, and maintain those at the facility and hand those out when people come in for their shift.
All righty, Bailey, what are you all doing in terms of infection control?
Here at Dr. Burton's group has done. So we had a task force in the beginning that looked at all of the PPE. We have team members that work on getting donations of PPE as well as purchasing PPE that we need, and we keep an inventory of it that is ongoing. We as well are storing them, like Dr. Burton showed on the picture. We have a very similar clothesline that's at the front of our building. However, our building is a little bit different right now because we do have COVID positive cases at James L. West. And so we have been using N95s for all staff. So every one of our team members, when they walk in, they initially get screened. They get their mask out of the brown paper bag, and they wear it the entire time they're in the community. And then as they leave, they will then take their mask off and store it in a brown paper bag. And the brown paper bag is used to kind of draw out the moisture of them. So that's been a recommendation that we have gotten. We've also been working with our local fire department. They have the ability to clean N95 masks. So we turn in all of our masks that are able to be cleaned, and they clean them and then return them back if they're able to be salvaged. And so we're able to reuse them, so we're not going through a lot of the city's supplies. On our residents who are COVID positive, we are using all of the recommended PPE. There is a gown that we have gotten sewn for us, and it's out of house wrap, and so you actually can wash those and reuse them. So if you're in need of gowns and unable to find them, that is an option that we have found that we're using. So we're in Fort Worth, so
Excellent.
kind of give a little background.
And Matt, can you talk about what MedStar is doing?
There we go. Thank you, Susanna. So MedStar, as many of you may know, is an EMS provider, ambulance provider in the Fort Worth area. And we started early on in this process managing PPE in a very unique way with our 911 call taking process, trying to identify what patients that are calling 911 might be at high risk for potentially being COVID positive, or certainly being at risk for that, so that we can work with not only our personnel, but the first response personnel to alert them ahead of time, do a little caucus before we go in, unless it's a truly time life sensitive condition, but as a way to sort of preserve PPE. It was a huge issue for us in the beginning. We were able to, thanks to a lot of support from the community and some innovative buying processes, we were able to obtain enough N95s for our folks. We've also gone to a different type of PPE now called P100, which is each employee has their own, and we just changed the filters. Part of that process was educating our folks on proper PPE use and all that kind of stuff. Our PPE use went from an average of 4 N95 masks per day to where it is currently at about 160 per day, which is good because we're being very careful out there. But also we started screening all of our personnel, talking about the staffing considerations. So we locked down our building. There's only one way into our facility. When folks come to work, they do an online health screening. Then they have a temperature taken. Assuming that they answer the questions appropriately and don't have a fever, they get a wristband that shows that they have been COVID screened. That assures that everybody in the building who's wearing a wristband has been COVID screened. But more importantly, for our healthcare system partners, when we go into hospitals and to skilled nursing facilities, they know that that employee has been screened at least in the last 12 hours, if not sooner, and they're not exhibiting any signs or symptoms of the coronavirus. We're also working with the State Department of Health Services, HHSC, and our local health authority to go out to facilities and assist with training in PPE. Thanks to Bailey, today we started doing a train-the-trainer program for N95 fit testing. So we're deploying those resources out there today into the field to help with the skilled nursing facilities. And we're also doing some hotspot testing, working again with those same agencies that going out to facilities, long-term care facilities that are identified as hotspots or at risk for becoming a hotspot, doing the facility assessment, but more importantly, doing coronavirus testing for all staff and all residents and providing those tests to the local lab for evaluation, just as a way to help continue, especially now that we're moving into sort of a facility focus, make sure we're doing all that we can in partnership with our partners to limit the spread, especially in the facility.
Thank you. And I have a quick question for Elizabeth Tommy. Are your surveyors visiting every nursing facility and assisted living facility to make sure that their infection control meets the state required standards?
Yes, we are. We're going to as many facilities as quickly as we can, both nursing facilities and assisted living facilities. And we are utilizing the protocol that has been developed by CMS for the federal as well as the state protocol. Both of these assessments can be found online, and facilities can also access these and perform a self-assessment ahead of time. And when our surveyors come on site, then they can go through this with the facility. If the facility's been able to do a self-assessment, then they already have a good idea of where their holes might be in their infection control processes and can start beefing up on those. We're trying to do this as a proactive measure and get to as many facilities as possible. We started this back early in the beginning, at the beginning of March, to try to help facilities get ahead of the curve and stay ahead of the curve to bring their infection control processes online.
Fantastic, thank you. All righty, I think we can move to the next slide. And as we continue talking about staffing considerations, we're interested in hearing about how new admissions are being handled, how meals, group activities are being addressed, who's considered essential personnel, and how are smoke breaks being handled. So would like to hear from Dr. Burton Bailey and Patty Ducaille on these questions.
Yes, thank you. So just to give a little bit of context, we look like sort of a typical long-term care facility. We have, it's just one floor, and ours is separated into 3 units. And so we have a secure unit, and then our second unit is our largest, and our third unit is closest to the main entry where staff come in. When we have new admissions, to start off with, we don't take any patients who have tested positive for COVID, who were COVID positive in the hospital. And so we do require a negative test prior to admission. And if they haven't had that because they were admitted for something completely unrelated and didn't have any symptoms and happened to not be screened, we do screen them within the first 48 hours of admission. They spend the first 14 days on the third unit where they are under contact and droplet isolation precautions. We have limited staffing who visit these areas. And we try to not have staff spend time on the third unit and the second unit and the first unit. We try to keep nursing staffing to the specific unit that they're assigned to not intermix and mingle. And then they get that first test within 48 hours, and then they get a second test at 7 days. Testing takes about 48 hours to come back. So we get the test while they're still under isolation. And if they have 2 negative tests, then they leave isolation precautions at day 14 and usually get moved off of the third unit to create space for other new admissions.
Thank you. Bailey, can you talk about what you all are doing in terms of meals and group activities in light of?
I want to talk a little bit about the new admissions really quickly, because James L. West is actually a long-term care facility down in downtown Fort Worth. And so we're a little bit different than Dr. Burton. So I want to give you an idea of what our building looks like as well, because it'll carry on throughout the questions. We have 4 stories and 5 units of residents. All of our units have residents who have a diagnosis of dementia. And so they range from mild, moderate to severe, and they are separated in houses according to the level of what stage they're in dementia. And so we also have a day program that we typically have open, but because of COVID, we have got it shut down, and we have turned that into our COVID unit. And then with our admissions, since we actually have COVID positive residents in our building, the health department comes in whenever you report that you have COVID positive. And if it's more than a certain number and that number changes, they will actually give you a control measure. And so we have a control measure on the building saying that we are not allowed to have any admissions in and no residents out at this time. So we are stopped on admissions right now, but we would follow pretty much the same procedures that Dr. Burton expressed earlier.
Thank you.
Mm-hmm.
Patty, can you talk about which personnel are considered essential?
Sure. So I'm Patty Ducaye with the Ombudsman Program, and CMS and really state government hasn't provided us with a lot of detail about what are essential services and who those providers are. But I know some things from what's available to us in writing, and also I know some things based on questions and answers that have been provided by HHSC over the last several weeks. And so one question we often get is whether beauticians can be an essential service provider, and the answer we've received from HHSC is no. So beautician services don't qualify, but many of the care providers inside a facility are essential care providers, and then outside providers can also be qualified as and considered essential care. So that may be hospice providers, especially at the end of life, but also potentially hospice providers for hands-on care that's needed, that's specialized for a resident in a facility. It is really a case-by-case basis when it comes to people who aren't employed by the facility and whether they're essential care, and that will be determined by the facility and can be done in consultation with an ombudsman and other help.
And I skipped over the question regarding smoke breaks. So Bailey, can you address how you all are dealing with that issue at James L. West?
So we actually don't have smoking. I think that's Dr. Burton's question,
Okay.
but I will address how meals and group activities are being addressed. So at James L. West, we're following all the recommendations from CMS and HHSC on encouraging our residents to remain in their rooms. However, with dementia care, if you work in dementia care, you know the struggles here, that residents don't always follow the rules and the guidelines. And so you have to do your best in redirecting them. And so all of our staff have been trained to encourage them to remain in their rooms for meals and encourage them to do activities and doing one-on-ones. However, that's not always the case. So for meals in particular, we are encouraging them to eat in their room, but they will come out in the dining room at times. So you've got to look at the environment. And we preach this here at James L. West is environment, environment, environment. So setting up your environment in order to encourage residents to socially distance, and then encouraging them to stay in their room. If there's nothing to do in their room, they're not going to stay in their room. So we have to get creative on the approaches that we take. And so meals for sure we're encouraging in the room. I will tell you, whenever we got our first COVID positive case, we switched everybody to using paper plates, which significantly decreased the amount of intake that our residents were having. And so we identified this quickly, and we're working on transitioning back to regular plates because it's something about eating on paper they just did not like. We've also found that the social isolation and having families out of our building have caused some stress and anxiety for our residents, and we really believe that the weight loss that we're seeing in our building during this time is due to families not being let in, as well as some of the environmental changes that we've had. So you want to keep a very close eye on your residents, especially their weights during this time, if you're working with residents with dementia or without dementia. And then with activities, like I said, we're doing one-on-ones as we can. However, again, they're going to come out. So if you're doing small groups, again, set the environment up. Put your chairs 6 feet apart so that they're not sitting next to each other, or they're not tempted to sit there. And then continue to remember that we have to still meet the residents' areas of wellness. And so I've met with our life enrichment group, and we talk about how are we going to meet their physical, spiritual, social, emotional, intellectual. How are we going to continue to meet these needs of our residents with activities, even though we have the social distancing, the families not coming in. So continuing to do, an example is, and I've trained the activity staff on thinking infection control. So your life enrichment team is not naturally like nursing, thinking on infection control. So you want to train them to think. Instead of ball toss with your hands, which is an easy example, do kickball. Okay, so they're not touching those surfaces, but they're still able to engage. So if they're doing hallway activities or doing one-on-ones, there's ways to think infection control and continuing to meet the areas of wellness. So there's a ton of resources, and I got Susanna and Donnie to put the resources on the PowerPoint so y'all can go and look those up. We are doing video conferencing with families. We have it set for an hour during the day, and all of our families know to be waiting on the phone or by the phone. We have a schedule set up so our life enrichment team knows who to call and when to call. And we're doing those once a day for 1 hour, so it doesn't just overload all of our team members. And those have been going really well. However, with dementia care, again, you might have the struggle of them not understanding who they're talking to or where their wife is, and they go looking for them. So just use your clinical judgment on whether or not it's beneficial to the resident. If it's not beneficial, you can do other things like have your staff interacting with the resident while they're watching on the video. So there's ways to adapt and change the activity, and allowing families to see their loved ones and the loved ones to be able to hear their family members as well, which is extremely important right now.
Excellent. Thank you very much. And Dr. Burton, did you have anything that you would want to add in terms of managing smoke breaks?
Yeah, so just to address that question, because we are one of a few facilities in Tarrant County that do allow for smoking. So previously, long before COVID, we had changed from sort of having smoke breaks freely to 8 shifts a day. And because of the social distancing rules handed down by CMS, we have made that into 2 separate. So there's 8 by 2 sessions, and they're separated by 20 minutes to allow for staffing to assist our residents in and out of the courtyards that we have where they do their smoke breaks, and so that there's fewer people going out during each smoke break. They're encouraged to socially distance, and having separate breaks like that spaced out allows them to do that. And just because, yeah, we knew we had to address that because that's just another part of infection control with smoking. They're, doing an activity that blows out small particles and things like that. So that was something we specifically had to address. Along the lines, sort of to piggyback on other things that Bailey said, we too are, focusing a lot on the whole person for wellness, and encouraging to continue activities as we're able, just with social distancing, as a big part of it. That took a couple weeks at the beginning as people, sort of self-isolated, but people are coming more around to engaging in activities more, and just realizing that they have to be a little bit further apart to do it.
And we are running just a little bit behind schedule, so thank you all for the detailed responses, but we may need to kind of pick up our pace just a little bit to make sure that we cover all of the topics. We did have a couple more questions related to staffing considerations and staff morale in particular. And the questions are, how do you maintain the mental health of staff? How do you demonstrate appreciation and support to staff? And Barb Hardy, would you like to weigh in on these questions?
Well, one thing that several of my facilities are doing, and we're contributing also, is bringing food in for lunch and dinner. And they have really appreciated that, the staff has, because that way they don't have to worry about packing something, getting it in. They're already working long hours. And one thing we've noticed is putting on all the PPE is just exhausting. And leaving it on, the face mask, the face shield, everything you have on can really make you tired. So when they go home, staff goes home, they don't want to have to worry about fixing something for lunch the next day. So that has been a good boost for morale. Another thing that my facilities are doing are trying to keep the nurses in the same units. That way they know everybody, and it's not quite as stressful trying to have new patients they don't know. We're encouraging them to take time off if they can. We're encouraging them to do activities. We've had different days, like casserole days, where different foods brought in, wearing different outfits sometimes, funny hats, whatever, anything we can think of just to, kind of boost morale. And then, of course, it's hard because some of the hospice patients, are not, the families can't come up unless they're actively dying, and that's a little hard too. So we're just encouraging them to talk to someone or to talk to each other, share their experiences, and just doing our best to keep their morale up. And it seems to be working. James L. West, where I go, has done a great job with the food and the keeping staff entertained when they can. And so that's helped a lot. And also having someone to talk to. We have social workers available. So overall, the staff I've worked with seem to be doing pretty well with it.
Excellent. So we do have 3 topics we'd like to cover, and I know there's a whole lot more that we can say in terms of staffing considerations. But in the interest of time, let's move ahead to resident care concerns and start with a conversation regarding physical and mental health, the monitoring that's being done, what's being done for residents who have chronic lung disease and have been prescribed breathing treatments. How are you addressing feelings of isolation, any exceptions to family visitors such as during end of life? And Dr. Ross, can you start off talking about physical and mental health considerations? And then I'd also invite Dr. Burton and Patty to join in the conversation as well.
Thank you. Yeah, one of the things with regards to kind of trying to identify cases early and recognize if the infection is present is just regular monitoring of those patients. And so temperature checks, O2 sat checks twice a day, something on a routine to be able to monitor. And I'm talking about all patients throughout the building. So something simple like a temperature and an O2 sat check twice a day to track those numbers can be of a benefit. Obviously, we know that individuals can present differently. Older adults may or may not spike a fever or may not have some of the same symptoms. But we've already talked, about isolating and or testing any new admissions, and both prior to and hopefully prior to and implementing in the moment, identified spaces for COVID positive units within buildings. So, in some situations that might look like the end of a hallway with a plastic wall just installed for a barrier, depending on the architecture of the building, that might be a little bit easier or a little bit more difficult. And the other thing is just still going back to our basics of the hand washing and hand hygiene. So keeping the gel stocked up, the soap stocked up, something simple like that is super important. Making sure that the supplies are in stock so that we can perform proper infection control as individuals with regards to hand hygiene, and encouraging folks to stay home if they're sick, and wearing the face masks within the building. So all of those things become very important just with preventing spread and entry into the building. The topic of the breathing treatments, one thing we've learned in this process is the concern with nebulized medications, kind of like we were talking about with smoking, pushing those particles into the air. The same is true of nebulized medications that patients might receive. So utilizing a metered dose inhaler with a spacer and a mask, or a metered dose inhaler by itself, is a preferred alternative to a nebulizer treatment if there is COVID in that facility, to prevent spread of the infection.
Perfect. Dr. Burton, anything you would like to add?
We're a facility that doesn't have COVID, but because of knowing that there could be several days of being asymptomatic, early on we reviewed who was on nebulizer treatments, looked at how often they'd been using them, and changed everyone that was on it based on those factors, to just being with an MDI with a spacer early on. As far as some of the isolation and sadness, in our facility, we have the real benefit of having psychiatry and psychology who comes out to the facility. And so in addition to the temperature checks and O2 checks, staff is asking about people's, sort of how their mental health is doing overall. And, when we check them for their regulatory visits, we make sure to check in on those feelings of isolation and make early referrals for counseling with our social worker or with the psychologist.
Excellent. And Patty, can you begin on exceptions to family visitors?
Sure, and just a note about isolation and sadness too, from the great examples that Bailey gave you for activities and what Dr. Burton just said about healthcare professionals providing psychological assistance, also connecting with family members has got to be a strategy you all are employing. Nursing facilities and assisted living facilities are required to connect residents with family members or friends that are important to them, and that can be through window side visits if they're in town, and if you do a window side visit, that's with the window closed to help prevent the spread of any potential pathogens. But then phone calls, Skype video calls, and you heard the good suggestions from Bailey, I think, again, about having schedules that I've seen many facilities do and do very effectively, and that will mean so much to residents and combat their isolation. On exceptions for visitors, yes, CMS has explained there are exceptions. They're generally referred to as compassionate care situations, and that has been described to us as someone who is actively dying, whether they are on hospice or not, but actively dying. And CMS then released it's been about a week and a half, in one of their memos, and it's QSO Memo 2028. And it also describes a person having a sharp decline in their health as potentially meeting the criteria for compassionate care visit by a family member. So that's something that others can explore, and again, will have to be worked out with the facility's decision. But those are the exceptions that we have received guidance from CMS, and then HHSC has provided guidance to both facilities, nursing and assisted living.
And it's Dr. Ross. I'm going to jump in with one more comment on the end of life. I think it's important to give family members options. They may not want to come up, or they may want to, be there. And it is if the facility has COVID positive cases, the recommendation for that family member who's made a visit to that building is to self-quarantine for 14 days after that visit. And so that's another consideration when looking at allowing, that compassionate essential visit for end of life connection with a nursing home resident. And, again, just giving them options, because some may really need to come see the loved one face to face, and others may not feel that it's something that they want to do.
Thank you, Dr. Ross. Okay, we'd also like to talk about special considerations related to dementia care, how to decrease anxiety for residents with dementia, how to handle residents with dementia who are not able to isolate, and effective strategies for residents with dementia. And would invite Dr. Knabel and Barb and Bailey to weigh in on these topics.
Yeah, so one thing I wanted to mention here is a really great resource is AMDA, Society for Post-Acute and Long-Term Care. They actually have developed some specific guidance on care for residents with dementia. So I'm going to take a bit of the approach from what we can do for considerations for staff. So one of them, we can be really aware of our nonverbal communication. During this time of pandemic, we're upset too, but that's not a good thing to display towards the persons with dementia that we're caring for, because they will pick up on that. So trying to check our own nonverbal communication, really trying to keep the care in our care interactions, because there's lots of opportunity to help with activities of daily living, and taking those not just as tasks, but maybe as an opportunity for engagement with the person with dementia. Consider using simulated presence, where family members can actually video themselves with very positive messages for their family member. I had one that actually did that, and it worked out beautifully for his wife, where he was there on the video doing that. And then maybe saying yes more. So when residents want to do things, saying, yes, we will do whatever. Instead of telling them no, we know how that goes over and will cause more distress for both parties. So just a few things from what we can do maybe as direct care staff. And then I'm sure Bailey can comment on some other things the West Center has been doing.
I think you covered it really well, Dr. Knabel. Yeah, so just engagement. I mean, being present in the moment, I think, is really important for all of our staff to understand. And the little bit of time that they're with the resident, continue and be focused on that resident. And then document. So we're attempting to keep them, socially distanced. We're attempting to keep masks on them. And then when they won't or aren't able to, then we just need to document those things.
All righty. So let's stay with the theme of resident care concerns and talk about family engagement, how to keep the family members involved, and the types of communication that should occur. And I would invite Barb, Dr. Knabel, and or Bailey to speak to that.
You're on. Jim, start.
One thing, well, like we've said at the James O. West Center, we have FaceTime. And that's been wonderful. I usually do a lot of the care plans for the family members, and they really appreciate it. It is a bit challenging with people with dementia, of course. They may not understand the FaceTime, but overall it has worked well. And I think just hearing their loved ones' voices has helped a lot. And for those who can't quite understand the screen and everything, just the phone calls, allowing a lot of phone calls, just hearing the voice, and it helps the families too. So that's helped keep them involved in care. And also they're delivering different things to the residents. Cards, puzzles, some different things, but cards and pictures. If they can't be there, I see more and more different cards coming in, and pictures and of the grandkids. And the staff usually knows the family members pretty well, so they can sit with the resident and say, this is here's your wife and here's your grandkids. And I've really seen the residents kind of light up. It's been difficult in some ways, and in other ways, it's actually gone okay. And I think using redirection. I had a lady this morning just wanting to go to the airport, And, you know, someone said, well, the planes aren't flying. But that's all she said. Right now, the weather, she made some excuse. And then we kind of redirected her into something else about her family. And, you know, you can use dementia like a light switch. We switched her to something else. She calmed down. She was happy. Everyone got around her. So I think just keeping the families involved and being available. A lot of them are very nervous. They're calling quite often. And every time one of our team sees a patient, we call the family and give them an update. And they're very appreciative of that.
So, Donnie, I'll jump in. So 3 weeks ago, before we actually had COVID in the building and we shut families where they couldn't come and visit in the facility, we started a FaceTime video conference with our families once a week. That has helped tremendously because when we got COVID in the building, we were already telling them our processes. We were already being transparent as what we were, hearing from CMS and hearing from HHS and the health department. We were being very transparent and open. So when we got COVID, they have all been so supportive. I mean, our calls have over 80 family members on them, and it has tremendously helped the families in feeling like their loved ones are being cared for because we're very transparent and open with what's going on in our building.
Well, thank you. If we can move to the next slide. Last couple of questions related to resident care concerns. How are healthcare appointments outside the facility being managed? And how are you managing regulatory and chronic disease management visits within the facility? So I would invite any of our doctors to speak to those two questions.
Hey, so here at Arlington Heights, we early on when they started limiting visitors, we took a look at our follow-up schedule. So for anyone who is having to go to an appointment, we looked to see if it was actually, like if it had to be done, if it was an urgent visit, and if it wasn't, we called and tried to reschedule it with the specialists to try and limit going out of the facility. For our surgical patients who have come in needing either trauma surgery or like an amputation, for example, they still keep their visits. We keep the driver outside the facility, and our techs, our resident care specialists, go and collect the resident, make sure that they have a mask, and they go with them. They go with the mask to their appointments, and they're supposed to keep that on the entire time that they're gone from the facility. And same thing for our patients who are getting dialysis. They also are to keep a mask on the entire time that they're out of the facility. That's how we've been handling it.
Okay.
The other thing I'll chime in on is connecting with the specialist. I had a patient who was scheduled for a routine cardiology follow-up, and I was able to get on the phone with the physician's assistant at the cardiology office and just do basically a med reconciliation and kind of report on some blood pressure numbers. And so, we at the facility basically have the data they need. So if it's a patient who, whether dementia or not, but may not be able to participate in like a telehealth visit with a specialist outside, the nurse practitioners and physicians on site at the facilities can be that liaison to share data with those specialists that they might see routinely. And the question that just popped up maybe for Dr. Burton to answer is, are we having any concerns about precautions with the dialysis residents inside the facility? Good question. As far as if they're going in and out, do they have any different precautions there? So
no, we haven't changed any. We haven't put them on isolation or done any extra beyond usual PPE for them.
yeah, and where Dr. Knabel and I are concurring with that, that's part of their routine, and that's not the same risk level as being hospitalized or other situations that might cause them to be out or potentially be at a higher risk. And with regards to the regulatory visits in the beginning, we kind of put those on pause and continue to go to our facilities with just checking in on whoever needed to be checked in and kind of putting those regulatory visits to the side. Obviously, as time goes on, we still need to be checking in on everyone and, basically limiting the face-to-face contact with residents. The close contact is the name of the game. So continuing to do those regulatory visits with a brief face-to-face physical encounter with the patient, and kind of the bulk of that time reviewing, reconciling medications, interacting with nursing and other staff to get the scoop on what's going on and whatnot. So that's kind of been our approach to the regulatory visits. There will be the possibility of doing telehealth, and I know some folks are already doing telehealth visits for both assisted living and nursing facility patients. So that's also an option.
Super. Thank you very much. Alrighty, so let's move to our third and final topic, which consists of considerations for the new normal. And the questions that we'd like to address: adaptive measures that may have been implemented in medical care staffing and use of PPE. What's the estimated timeline to return to normal operations? What considerations should be taken to ensure resident and staff safety when facilities reopen? And would like to hear from Elizabeth Tommy with long-term care regulatory, as well as Dr. Knabel, Dr. Burton, and any other panelists who would like to weigh in on these topics.
So from Health and Human Services Care Regulatory, of course, we're regulation driven, and so we are going to keep our finger on the pulse of the direction that is issued from CMS, Centers for Medicaid Medicare Services, for those facilities that are federally certified as well as state licensed. The state licensing requirements are going to mirror those fairly closely. And of course, we have to take into consideration any directives or orders that are placed by the governor and or by local city or county health officials, such as county judges. And health departments also sometimes will put a control order in place. And the bottom line is all of these resources typically are stemming from the direction from Centers for, or CDC, and trying to meld all of those things together to make sure that the residents in the facilities have the highest possible health and safety measures in place for them. So right now we currently are under directives from CMS and through state provider letters that are restricting visitors. So those are lifted. The facilities are going to be restricted to a large degree on how they can lift those current measures that are in place. They also speak to the use of PPE, communal dining, different communal activities, and of course the social distancing, which is, all of these issues are touching every aspect of facility life and the staff life. So we're going to be monitoring that really closely to see how those directives change and how that can be applied to the facilities, what that means for facilities moving forward. And so we will try to work to support that in any way that we can. And of course, we'll be a resource for facilities as things do start to open up at some point. We will be able to offer guidance on that topic and help them work through those questions and considerations that they may have.
Thank you, Elizabeth. Dr. Knabel?
And so these are challenging questions. Sort of to dovetail onto what Elizabeth's describing is obviously there's lots of federal, state, local input that is going to occur in terms of the type of opening up. The opportunities to have families, of course, to come into facilities and where we're going to be going, because obviously the PPE has been really critical, and then the ability to test the ability to test and get results back appropriately, how often that needs to occur. All those kinds of questions are going to have to be answered, and how can we implement this? However, I think that some of the things we are doing now, such as utilizing the telehealth modality, I think is going to possibly continue to be more a part of the way we are going to do healthcare in the future and effectively. So how do we utilize that? I think the communication that has occurred because of this is also a good thing. So there are some of the things we're doing now that I think are very positive moving forward. What will be the new normal, I don't know. Certainly it's going to be different than what we've done. And hopefully in a good way towards the care for those living within long-term care, not only locally, but throughout our state and our country. How do we improve that? How do we do better at infection control in general? Because this is one pandemic, but we have other types of infection control issues that are very important. And so, for example, we've got the flu season that'll be coming. We need to do a really great job on immunizations for influenza. What about pneumonia? Are all of our patients and our staff that need to be immunized, are they all up to date? I think we should take the opportunity now to think about all of those things and certainly the basics, washing our hands, how we manage day in and day out. I hope we're all going to become more cognizant of that, or maybe we're all going to practice better. So.
Dr. Burton, anything that you would like to add?
Yes, I just want to echo what they were saying. That CDC and CMS are the ones handing down a lot of the guidelines. So as they're monitoring the situation, as we get more testing and are monitoring at the state level to provide information on up, that'll sort of give guidance as to how things progress in terms of reopening. I want to applaud the James L. West Center for how great they've been in their communication with families. We've also been trying to be in contact with our families as much as possible, and I think that transparency will go a long way towards them understanding next steps. And I think the things that we've learned during this time, like the increased use of PPE, like telehealth, like using FaceTime, are all ways to help, control infections and improve resident life, during times of COVID and when it diminishes.
Fantastic. Well, I share that we are at the top of the hour, so I would like to give you all instructions on requesting continuing education units. Also let you know that you will receive a follow-up with both the slides and the recording. So you will have access to the resources that you see on these slides. And the program evaluation is on the last slide. And I believe Susanna is going to be emailing that out to you. We will offer complimentary continuing education units for licensed social workers and professional counselors. If you're interested in receiving those, you are required to listen to the entirety of the hour program and complete the evaluation after the program is over. And I'm going to ask that you send me an email. My email address is dgreen@nctcog.org, certifying that you did participate in the entire hour program and complete the evaluation. And I will email a certificate back to you. I apologize to folks who submitted the wonderful questions regarding chat, that we weren't able to discuss those during the body of the presentation, but I do see that we have several presenters who have responded with a lot of detail to your questions, so thank you for that. I would also ask if any of our presenters might be willing to stay connected for just a few minutes longer and see if we might be able to respond to some of these questions that we were not able to discuss during the program. Fantastic. I see some heads nodding. So let me read at least a few of these questions and see if we might be able to respond. The most recent question is pretty detailed. It says, new admission, antibody positive, active COVID, double negative in 24 hours, quarantine or isolation?
I mean, just going along with our protocols, I would probably still quarantine them just for monitoring of symptoms.
Okay, and I see Bailey nodding her head. All right.
Yeah, isolation is determined, is instructed for when there is a positive case of COVID-19.
Okay, thank you, Patty. And ironically, my mouse just died. So I am not able to scroll up to see the other questions.
I think many of the other questions got answered via the chat.
Fantastic. You all are so good. Obviously used to multitasking. All right.
Did you all answer the question about the governor's order for testing?
No.
Yes.
I didn't
Patty.
see that one.
Yeah.
That might be good to comment on. I'll start.
Yes, please.
Again, this is Patty from the Ombudsman Program. And so late yesterday afternoon, the governor announced that HHSC and DSHS would be directed to test all nursing facility residents and staff. So one of the questions I saw was, would this apply to assisted living facilities? And given he says nursing home in his directive, I think the answer is no, not at this time. And the other question I saw related to that was how many times someone would be tested. And the answer right now, I think, is a solid we don't know. There will have to be some protocols developed. I'm sure there will be a process that will be, all facilities will be instructed about how that needs to happen. But at this time, I don't have more information about how that will happen.
Okay, super. Thank you, Patty.
This is Elizabeth Tommy with HHSC. And also, just to piggyback and echo what Patty said, that is also our understanding and regulatory. But I would like to add that for facilities in Texas, assisted living facilities, that we do have a process for that is online currently, where when a facility notifies Health and Human Services as well as the CDC and their health department that they do have their first COVID positive case, whether it's a staff or a resident, that regulatory is making every effort to visit that facility very quickly. And we're performing what is called, a rapid response assessment request and determine if the facility does have need for testing. We do have some resources where we can escalate that and ask for an activation and get a rapid or a quick response force on site that can be dispatched through emergency medical task force, as well as combination of state and local efforts that can provide testing. So that would be on a case-by-case basis, but thankfully that is something that we can activate for assisted living facilities at this time, as well as nursing facilities.
What if an employee refuses to be tested?
That is their right. Any employee or resident can refuse to be tested. And yesterday I was looking at the governor's announcement on that testing would be performed on all staff and residents. So I think it's going to be interesting to see exactly how the order is written and how that's executed. Patty, do you have any additional information on that?
No, but I certainly agree with the perspective that, no, I agree with you.
Okay.
I think there's a lot more information needs to come out about this. So I know everyone is pretty excited and we have a lot of questions, but I think it's just too soon to be able to answer some of them.
I agree.
There was one more I wanted to pose as the last question, but I'm not able to go back to it. So, but the presentation will be able to be replayed again. You will be getting a recording of today's event. Again, I want to thank all of our participants for joining us today. I do encourage you to complete the evaluation. And again, if you're interested in the CEUs, please send an email to me, dgreen@nctcat.org. I would also ask if our presenters can stay with us for just a few minutes longer as we debrief. But for everyone else, that concludes today's training program. Thank you again.